our lecture series on Beecham and Childress's Principle of Justice, we're going to look at allocating, setting priorities, and rationing. Throughout this week, we've been looking at the Principle of Justice in terms of distributive justice. So distributive justice is about the fair distribution of finite resources. And so that's why Beecham and Childress have this discussion about allocation, setting priorities, and rationing. So let's begin with allocation. Beecham and Childress talk about four distinct but interrelated types of allocation. These appear on pages 279 to 280 if you want to check it out. The first place in which there is an allocation is with the comprehensive social budget. So not only health, but other social goods such as housing, education, culture, defense, and recreation. We make decisions about budgeting a set amount of money to ultimately divide up between those different concerns or those different interests. Then winnowing it down as we keep going, the next step is to look at the health budget itself. So out of all of those social goods, there is a type of allocation to health, and this will include not just health care or like insurance, but this also includes public health, disaster relief, poverty aid, occupational safety, environmental protection, injury prevention, consumer protection, and food and drug control. All of these are aspects of the health budget. So this is a larger chunk of the money. Then the next step in the allocation is a more targeted budget, where decisions are made about certain projects or certain procedures. They talk about how there'll be decisions about specific types of injuries or illnesses or diseases that should receive priority, about how or how much of the budget that they receive and when. And Beecham and Childress say that it might be justified, for instance, to concentrate less on fatal diseases such as some forms of cancer and more on widespread disabling diseases such as arthritis. That's ultimately a decision about how we divide up this chunk of money or these resources. And then finally, we have actual scarce treatments, so the patients who are going to receive these treatments. And so the idea here is that it's budgeted for certain patients or certain classes of patients. Beecham and Childress say that at various times and in various places, medical resources and supplies such as penicillin, insulin, kidney dialysis, cardiac transplantation, and space and intensive care units have been allocated for specific patients or classes of patients. So the whole idea here is you have a larger pool of money. It becomes reduced as you go from one step to the next step, but they're obviously all interrelated. And what Beecham and Childress say here is that typically what we're doing here in bioethics, if there is distress in the choices that are being made for this step 4, so the scarce treatments that are allocated for specific patients or classes of patients, if we find distress there, that might prompt us to revisit our targeted budget and decide which projects might require prioritization over others if they're not consistent with what we think we should be doing within the field. If allocation is going to be successful, then we're going to need to set priorities that are consistent with our considered moral judgments and also our beliefs in a right to a decent minimum. So to do that, Beecham and Childress outline a couple of strategies about setting priorities with cost-effective analysis, cost-effective analysis and cost-utility analysis. Back in the beneficence chapter, they talked about cost-benefit analysis and a number of other utilitarian frameworks. So this seems to be the common way of approaching this issue of setting priorities. And just to be clear, here are the definitions of different terms that are used within these utilitarian frameworks. So a cost, the resources that are required to bring about a benefit, as well as the negative effects of pursuing and realizing that benefit. Risks, the possible future harms, where the harm is defined as a setback to interests, particularly in life, health, and welfare. Benefits, these sometimes refer to cost avoidance, but they also can apply to positive values such as life or the improvement in health. So again, I'm not going to talk about everything that's in this section. Rather, I just want to focus on the example of the Oregon Health Services Commission case. So the idea for this is that patients who are on Medicaid, they are trying to allocate the budget that they have to ensure this decent minimum of coverage. And what the Oregon Health Commission did, or does routinely, is that they try to create a list where different diseases are prioritized, and then what they do is they try to determine how far down the list that the funds can actually cover. And so the whole idea is that based on this prioritization of these different illnesses, the Medicaid will ultimately cover anything that is within the list of diseases that are within that priority range. Obviously, as Beecham and Childress discuss here in this section, this is easier said than done. How do you ensure that you are catching all the right diseases? And there are going to be different arguments about whether or not the list actually successfully captures all the things that we think, or gives the correct priority to a number of different diseases. The whole idea here is to try to ensure this basic decent minimum of coverage while also maximizing the return on the funds that are allocated to the budget. So I think one of the other parts within this section that I wanted to mention was the allocation for preventative care. So if you set priorities for preventative care, it seems to be more effective in saving lives and reducing suffering by raising levels of health and lowering costs. So if people go to see the doctor earlier, then things do not progress as far, and then they don't require as much attention or as pricey of treatments as if it would have been caught earlier. So I think that's a very general overview of what's going on in this section. I'm sort of going quickly over it because it's really a utilitarian framework. How are we determining costs and benefits? How are we weighing them? You're going to run into all those same problems. Beecham and Childress also just try to give their own personal argument for a unitary system, which is at the first tier of healthcare, and then a pluralist system at the second tier. And this should sound familiar to what we've talked about in the previous lecture. So again, check out this section if you want to look into it a little bit deeper. I'm just trying to give you the quick version. I think the important takeaways here are setting a priority list in light of this responsibility to ensure a right to a decent minimum of coverage. That seems to be Beecham and Childress's core argument here. And then also the idea that cost-benefit analysis, cost-effectiveness analysis, and cost-utility analysis, these are all just utilitarian frameworks to try to end up negotiating between the different concerns with a limited budget. Finally, let's look at rationing. I split this up into two different slides. So the first thing that I want to mention here is the three senses of rationing that Beecham and Childress note. So the first sense, rationing, is denial when there's just no resources available. The second one is when the government determines an allowance or allotment and individuals are denied access beyond that allotment. And then third, there's an allowance or an allotment that's distributed equitably, but those who can't afford additional goods are not denied access beyond the allotted amount. So the first part of that is egalitarian because we're talking about equity. Second part is more libertarian because it's about access to additional goods if you can afford them. And so Beecham and Childress are using all three senses, but they concentrate on the third. The second part that I wanted to talk about on this slide was the idea of rationing by age. And you see these two different arguments that are presented within the chapter here. So the first one is the quality adjusted life years. The sort of sentiment or the thinking behind this is that people who are older have already experienced a lot of life, and they may lack the capacities to get as much out of life as somebody who's younger. And so if you only have limited resources, think about a limited number of ventilators. Who should ultimately get a ventilator if their life depends on it? Well, if you argue on the basis of quality adjusted life years, you would say that the younger person deserves it because they have more quality of life ahead of them. The second argument is the fair innings argument, which is to say that, again, this is discriminating against elderly patients. The idea is that elderly patients have had their fair shot at a number of years of living, so why should they be allowed to continue on at the expense of somebody who hasn't had that same level or same number of years? And so you have these two different approaches that can ultimately discriminate against elderly patients. And as Beecham and Childress rightfully discuss here, all calls for age-based rationing face challenges. They say how such rationing risks perpetuating injustice by stereotyping the elderly and treating them as scapegoats because of increased healthcare costs and creating unnecessary conflicts between generations. Nonetheless, to protect the health of children and many vulnerable groups, we're certain to find that we have to set a threshold age beyond which funding for various conditions is not publicly available. So think about heart transplants for a 90 or 100-year-old person, right? So they're trying to take a very moderate view, but I think the key takeaway from this discussion is that there are these ways in which, when we are rationing limited resources and we try to take into consideration something like age, or age becomes a way to discriminate, it should be something that is reflected on and sort of engaged with to the extent that ultimately it would seem unfair, or it could perpetuate more of a stereotype. And I guess what I'm trying to say here is that it requires more critical reasoning than just simply appealing to these first two arguments in most cases. Next, Beecham and Childress outline these three different categories of criteria for screening potential recipients of scarce treatments. The first one is the constituency factor. So these are social rather than medical factors, and they're determined by the boundaries of the person who is receiving this scarce treatment. So think veterans who get medical treatments at the VA, the Veterans Affairs hospitals, or you can think about geographic or jurisdictional boundaries, such as being citizens of a legal jurisdiction served by a publicly funded hospital. The idea here is that these treatments are social goods that are ultimately allocated from the budget of the political unit, and so people who belong to that political unit might have a claim before anybody who doesn't belong to the political unit in a formal capacity. And so we get this idea of the transplant list being limited to citizens case. The second category is this progress of science. So this is more research oriented, and it's relevant during an experimental phase in the development of a treatment. So physician investigators may justifiably exclude patients who suffer from other diseases that might ultimately harm the result or the research results. The third category are these prospects of success. So if we're going to use these scarce treatments, then it might be justified to prioritize those who have a reasonable chance to benefit. And Beachman shows say ignoring this factor is unjust if it wastes resources, as in the case of organs that can be transplanted only once. So those are just three different categories of criteria that are sometimes used. Not saying that they all have to apply in every case. They're just a way in which to facilitate the rationing process. Up next, we want to differentiate between medical utility and social utility. So medical utility is the sort of the benefit that the treatment produces for the patient, and social utility is the good that produces, or the good that is provided to the society. I think the interesting case here that we see in the text, I think it's in this chapter or in this section, yeah, it's on social utility. The World War II case, I have it marked for page 291, in which there is a limited amount of antibiotics. Who do you give the antibiotics to in a war? Do you give it to the people who got hurt on the battlefield, or the people who developed an STI from having intercourse with somebody? You might, your first intuition might be to say, well, you give it to the people who got hurt on the battlefield because they deserve it. But if we're talking about social utility, you might give it to the people who are taken off the battlefield, but if because they have this STI, so that they can return to fighting, because ultimately the war is continuing and people who are severely injured aren't going to be returning to the war. I'm not trying to say that that's necessarily the right decision here. I'm just saying that if you're going to make the argument based on social utility, then ultimately you might deny soldiers who are hurt on the battlefield this medicine for ones who have some other disease that is just preventing them from getting on the battlefield. That's the difference between social utility and medical utility. The other part of this rationing discussion is what role chance might play in lotteries. So I think if somebody were to tell you that your access to a treatment is up to a flip of a coin, you'd be pretty alarmed or scared. I think that's how I would be, right? Like, my whole life hangs on the flip of a coin or on a lottery system. But Beachman Childress say that there are cases in which it might be acceptable because we're trying to make sure that the rationing is fair. Because if the alternative is that people who belong to certain groups have better access, and you're not going to get it anyway, at least the lottery gives you a chance. The other interesting part of this section of the text is the idea of first come, first serve. So you might think that whoever gets there first should have access to the resources as long as they're available, and then if you get there later and the resources are used up, there is no blame for that. But they give us this example of the ICU case in which, in the NICU, different patients, or I guess different newborns who might need access to these, I'm going to screw this up, extracorporeal membrane oxygenation, or ECMO. Ultimately, who should have access to it? If it's a newborn with a poor prognosis that's on one of these, or within one of these, the argument can be made that it's not just because this newborn was there first, but if there's another one with a better prognosis, maybe it's morally permissible to take the one with a bad prognosis off to put the one with a good prognosis in. And again, I'm not trying to say that that is the default correct answer for this problem. I think the question here is about the first come, first serve policy. And the whole idea of this example is to elucidate how first come, first served is not necessarily a fair way of doing it, and it doesn't always match the criteria that we think we should use when rationing. So obviously something that you would have to think very hard about, but something that you might be confronted with on a regular basis, especially if you find yourself working in an ICU unit. So the last thing that I wanted to just briefly say was about triage. I'm going to do a short lecture later in the semester on triage. So here, if you're not familiar with it, triage is the French term which means to sort. And so triage occurs when we're trying to sort patients based on their need and the prospect of success, and it's usually in a very fast-paced environment, especially if it's after a natural disaster or something like that. There's also triage within the emergency room, but it's when decisions have to be made pretty quickly, so you try to establish certain rules about making the sorting happen quicker. So we'll talk a little bit more about triage later because it becomes really complicated. It's not as straightforwardly utilitarian as some of these other discussions, and I think it's really fun to sort of discuss how triage can be pretty complicated. So that's all I have to say about rationing. Now let's summarize. I will admit that I went pretty quick and I did not cover everything within this section. So again, if there's something that really interests you in this and you want to talk about it, please feel free to reach out to me. But here's what we did cover. Allocation, first off, happens across the hierarchy of budgets. We have a bigger pool of resources that ultimately get winnowed down once we reach to the sort of individual allocation of scarce treatments. Then we talked about setting priorities as being a challenge, but it's important to keep in mind that our goal here is a decent minimum of health. At least that's what Beecham and Childress' argument is. And then also it is worthwhile to contemplate the procedure in which we use to set these priorities rather than just focusing on the product. Next, we talked about rationing by age is sort of controversial, right? We talked about quality adjusted life years and fair innings arguments and said how that they can lead to unfair discrimination against people who are older. And then talked about different types of criteria that might be used to screen potential recipients. That was the constituency factor, the prospect of success, and then the progress of science. And then considerations of medical utility and social utility often affect our decisions. So medical utility is for the benefit of the patient, social utility is for the benefit of society. And then triage, as I was just saying, is just a method to distribute scarce resources in times of great need. And we'll return to this later in the semester.